South African National Defence Union is taking the Surgeon General to court over the COVID-19 vaccine rollout. So far, military healthcare workers have been excluded from the rollout strategy. The union's National Secretary, Piki Greef, says the Surgeon General missed yesterday's deadline to propose a vaccination plan. The union adds its healthcare members were promised vaccinations by mid-March, but this hasn't happened. Government has faced widespread criticism over the slow pace of its coronavirus vaccine rollout plan.
Health workers within the SANDF have complained to the union that whilst their colleagues in other public service sectors are being vaccinated in accordance with the government's Johnson & Johnson project, they themselves in the Defence Force have not been receiving vaccinations, and there was no program for them. Our lawyers then directed a letter to the Surgeon General urging him to indicate when military health workers would be vaccinated as their colleagues in the rest of the public service. The Surgeon General publicly undertook that such vaccination rollout would start mid-March, which then never materialized, and that prompted our lawyers to write a further letter to the Surgeon General informing him that we will be taking the necessary legal action to ensure that military health workers are being vaccinated or become part of a vaccination program sponsored by the state.
There are warnings that South Africa is heading towards the third wave of coronavirus with no concrete vaccine rollout plan. The country will need to ramp up inoculations to 250,000 a day over a 3 to 4 month period if it's to meet its targets. But South Africa currently doesn't have the vaccines to do this, despite attempts to secure them. We're joined by Wits University Professor of Vaccinology, Professor Shabir Madhi, and the Progressive Health Forum convener, Dr. Aslam Dasu. Good evening to both of you, and thank you so much for your time tonight. Professor Madhi, let me begin with you. Let's talk about these expectations, warnings about a third wave in South Africa. How real are they right now?
So unfortunately, it's very much a reality. In fact, what we've been observing over the past few days is an increase in what we call a positivity rate. That is a percentage of people that are coming forward for testing that test positive, and that has now gone back above 5%. In 6 of the 9 provinces, there's early indications that there's actually an uptick in terms of the number of cases. In terms of when the third wave will really materialize, it depends on 2 major factors, the one being people behavior, and in particular people engaging in mass gatherings, and the other being what happens with the virus with regard to further mutations. I expect that, unfortunately, we probably will start experiencing a third wave of significance around about the beginning of May, but it might actually occur even earlier if we allow for mass gatherings to take place, especially in poorly ventilated indoor spaces during the Easter period.
Dr. Dasu, this is going to become such a controversial issue because for a second year in a row, effectively, we're going to have over what is largely a religious period, people being encouraged either not to attend religious ceremonies, or even worse yet, they simply won't be allowed to do it because we could also see a tightening of restrictions.
Yes, really. This is an unfortunate situation.
Dr. Dasu, unfortunately, I'm not winning with that connection to you. I think there's something wrong with that line. I'll ask the team to try and redial you. But Professor Madhi, perhaps let me bring you back into this conversation just on the issue of the religious gatherings for a second year in a row that would effectively have to be changed, if not postponed. Do you foresee contestation, at least from members of the religious sector, and if government does continue to say that restrictions should be tightened during the Easter period?
Yeah, I'm sure the religious sector are going to be extremely unhappy, as is going to be the public. They're also going to be extremely unhappy. But the reality that we face is that what we understand in terms of the transmission of the virus is that close on to 80% of infections are directly or indirectly related to these sort of mass gatherings. So unless we want to experience resurgence much quicker rather than later, and unless we want that magnitude of that resurgence to be higher than what it could be otherwise, we cannot, unfortunately, afford this sort of mass gatherings, and especially these mass gatherings that occur in indoor spaces.
The reality is that the first quarter of this year hasn't unfolded according to plan when it comes to government's own vaccine strategy. By now, there was an expectation that at least phase 1 of the strategy would have been completed, but we are yet to receive vaccines that can be rolled out outside of this Sisonke protocol that is being undertaken by government and Johnson & Johnson. What does this mean for us as we approach this potential third wave?
Yes, unfortunately, it means that even if we start rolling out vaccine in the next 2 to 3 weeks, it's probably going to have a very nominal effect when it comes to the third wave, because you're probably wanting to give the vaccines at least 4 to 6 weeks before you get adequate penetration, even if it's only targeted at high-risk individuals, as an example. So for all intents and purposes, we still need to make every effort to get vaccines, as many vaccines as possible, into the arms of high-risk individuals as quickly as possible. But when it comes to what we can do with regard to mitigating the consequences of the third wave, we're going to come short because we've left it too late to make any significant impact on what we're likely to experience.
Dr. Dasu, I understand you're back up on the line. There are different reasons that government will give for why South Africa doesn't have vaccines right now. And some of these issues are not within their control, such as the capability of manufacturers to provide these vaccines. But when you look at the strategy of the state, do you think that there have been instances where they've let the country and the citizens of this country down?
Good evening. Sorry about this earlier. Look, there are a couple of things we have to consider. One is that we definitely start very late in acquiring vaccines.
Dr. Dasu, I'm so sorry. Unfortunately, that line to you is not any better than it was the last time. We'll try and speak to you again later on this week. Unfortunately, we're going to have to leave it there with you for tonight. But perhaps, Professor Mbadi, let me bring this question back to you in terms of the circumstances that are not within the government's control. But for those that are, do you think that we've been let down?
Unfortunately, I don't think the strategy was adequately thought out. Yes, there were some curveballs thrown our way in terms of, as an example, the AstraZeneca vaccine, not protecting against mild and moderate infection. But then at the same time, the World Health Organization recommended for that vaccine to be used even in countries such as South Africa, where the B1351 variant is circulating, especially for high-risk groups, and government and its advisors decided otherwise. So some of the doing is to our own making, where we've basically been scoring our own goals, in a sense. And at the end of the day, what we also experience is that we left the bilateral engagements way too late to be able to gain access to large quantities of vaccine at an early enough stage. So again, it's difficult to undo those sort of issues because South Africa pretty much needs to take its place in the queue when it comes to accessing whichever vaccine it is, having been so late in terms of engaging.
Of course, there was a lot of promise that, some of those initial problems that had been experienced would be overcome by the arrival of vaccines between, if not the first quarter, absolutely the second quarter of the year. Given just how much of a mammoth task it has been getting the implementation study vaccines for the Johnson & Johnson trial, do you think that at all is an indication of what lies ahead for any hopes of a rollout for the country?
Very much so. I think we underestimate the huge amount of logistics that goes into deploying the vaccine. Getting the vaccine into the country is one of the challenges, but actually deploying it and getting the vaccine into the arms of the people is a very different challenge. And right now, again, we don't have any indication as to whether we actually prepared to be able to vaccinate even tens of thousands of people per day, let alone 250,000 people per day. We're probably never going to get to 250,000 people per day in any case. What we need to do as a country is we need to reconsider what we're actually trying to achieve with COVID-19 vaccines, especially this first generation of vaccines, whose main utility will be to protect against severe disease and death. So we need to recalibrate our expectations of the vaccine, and then we need to redesign our strategy to speak to the realities in terms of vaccine supply, as well as what we're able to achieve with these sort of vaccines.
How would that strategy need to look like, Professor Madi? Because, you know, when we are speaking realistically, again, it doesn't look like we're going to get those vaccines in the country anytime soon. Does that mean that some of the measures that have been implemented need to start being re-implemented more vociferously as we approach a period that would generally be a traveling period?
Well, in terms of the traveling period, like I said, the big issue here is around mass gatherings. Traveling to another province and spending your time outdoors on a beach is not going to have any material effect when it comes to a resurgence. It's really when people start gathering into those indoor spaces which is going to cause problems with regard to the resurgence. But in terms of how we need to plan for moving forward to the COVID-19 vaccine, what should have been taking place right now as we speak, should have been occurring for the past few weeks, is that even if we think that we're going to get vaccine around about middle of April, what we should be doing is that people should already be told when they need to expect, when they would be expected to come for vaccination at different facilities. That sort of planning can't be left until the time when the vaccine arrives. That sort of planning should already be in place, that when the vaccine arrives, it takes nothing less than more than a day to start getting those vaccines into the arms of tens of thousands of people. But that can only happen if you've planned ahead as to who's going to get vaccinated, when and where. And that sort of planning is clearly not evident currently in South Africa.
Professor Madi, one of the other things that we've also seen is that there seems to be, you know, an application with SAPRA for the approval of the use of Russia's Sputnik vaccine and the Sinopharm vaccine that is being produced out of China. There have been questions about whether or not there's enough results, at least from trials, when it comes to the efficacy of both these vaccines to this variant that has been largely predominant in the country. Do you have any particular concerns where these two vaccines are concerned?
It's not only those two vaccines. The same thing applies to the Pfizer vaccine, which South Africa has indicated they've purchased 20 million doses. The Pfizer vaccine itself hasn't been tested clinically in terms of effectiveness against the B.1.351 variant. That being said, I believe that all of the vaccines, including the Sinopharm vaccine, including the Sputnik 5 vaccine, the Pfizer vaccine, the AstraZeneca vaccine, all of these first-generation vaccines are likely to perform equally well or similarly when it comes to protecting against severe disease. How these vaccines are going to perform against mild infection, which the AstraZeneca vaccine didn't prevent when related to the B.1.351 variant, is anyone's guess. But it's not just a Sinopharm vaccine. It's not just a Sputnik 5 vaccine. That applies even for the Pfizer vaccine. And in fact, even for the J&J vaccine that's currently being used. We don't know what the effectiveness of the vaccine is against mild infection. We know that it does a tremendous job in terms of protecting against severe disease, where it reduces your risk by 82%. But for mild disease, for many of these vaccines, except perhaps for a Novavax vaccine, which we evaluated in South Africa, we're clueless as to how well it will work against the majority of illness, which is usually mild infection. But that being said, like I said, the important thing for us as a country is that these vaccines still have probably got a major role to play when it comes in protecting against severe disease. And that's what we need to be focusing on.
So does that mean that an early approval, let's say, of the Sinopharm vaccine, which I understand would be made available to the country within 3 weeks if it's given the green light, would that be saving the day somewhat?
Well, there's a minimum amount of effort that needs to go in terms of evaluating the potential effectiveness of the vaccine. And at the minimum, we need to do some laboratory testing with regard to the immune responses that's induced by the vaccine, as well as how those immune responses compare when tested against the B.1.351 variant. And those sorts of studies probably take a minimum of 2 to 3 months to complete. So I would be very surprised having South Africa having shipped away the AstraZeneca vaccine, for us suddenly to adopt the Sinopharm or Sputnik 5 vaccine without that minimum body of evidence being made available.
Professor Shabir Madi from the University of the Witwatersrand, let me thank you for your time as a part of this conversation. And of course, we had to bid an early farewell to Dr. Aslam Dasu from the Progressive Health Forum. And let's